All right, guys, good afternoon or good evening, whatever you want to call it right now. I'm Rob. It's a pleasure to meet most of you guys again, and hello. So today I'm going to kind of work with my friends Jason and also Tramian to go over kind of the idea of the tilted implant concept. My goal tonight is not to be a salesman. My goal tonight is to kind of tell you why this is a good treatment for your patients, and that we got to start viewing, edentulous in a different light, more as clinicians than as salespeople or just carpenters. Okay. If there are any questions, please raise your hand or just kind of speak up during the actual talk. If not, I always leave my email and my office number. If any questions you want to kind of bring up later, please give me an email or just give me a call. That being said, the CE being offered tonight, everyone has to fill out those forms so we can get your email. We're actually going to offer PACE recognized CE, and part of it is to answer 4 or some questions in order to kind of get that PACE certification. So there will be CE. We'll email the actual link. They're 4 easy questions I personally wrote, so I know everyone can pass it without even really thinking about it. Okay. So again, it'll be all offered to you afterwards. So please just fill out those forms. So the first thing I want to kind of bring up to you is, kind of get back to your basic tenets of dentistry, okay? There's this idea that there's a separation between medicine and dentistry, all right? There's this wall, this imaginary wall that we all, kind of create. There's dental insurance and there's medical insurance. The problem is that it all functions inside the same body. We all have teeth, we all have hearts, we all have lungs. I can tell you I have cases of teeth going to the heart and lungs and the actual brain itself. So it's all connected, but somehow we've created this kind of barrier that, teeth are a luxury versus actually an organ, part of your actual body, okay? So we actually look at the definition of what is a disease. It's a disorder of structure or function in a human, animal, or plant, especially one that produces specific signs or symptoms or that affects a specific location. It's not simply a direct result of physical injury, okay? I can tell you personally, there's a lot of signs and symptoms of edentulism, of people who cannot chew, who cannot eat properly. So we have to start thinking about edentulism not as simply just a kind of a problem, but a true disease. Okay, there's epidemiology associated with people who are edentulous. There's social, there's medical and functional problems with not having teeth because it's an organ, not a luxury, and that's kind of the key here. We're treating patients. And we aren't car salesmen, okay? Edentulous defines the loss of all natural teeth and is an important public health issue. There's epidemiologists who actually study this, all right? It's obviously a health issue globally because it's high prevalence. About 10% of adults over age 50 years of age are edentulous, and it has associated disability. Remember the idea of signs and symptoms of a disease? Well, there's signs and symptoms of edentulism: enlarged tongue, overclosure, you get that sunken in face, that kind of the lips turning in. Associated with TMD issues. There's problems with speech, such as different pronunciations or different consonants that you try and actually articulate. There's just aesthetic issues and also, masticatory deficiency. And I'm sure that I'm, preaching to the choir, but my idea here tonight is not to simply just kind of, talk to you about the idea of having a really good prosthetic rehabilitation, but why and what we're actually offering these patients. It's to treat a disease, all right? Edentulism, as I said, it's a big problem around the world. About 90% of people who right now who are edentulous, who suffer from edentulism, that's the key, they suffer from it, just have normal dentures, okay? The biggest problem is we got to start, teaching at the dental school. I can tell you that there's this divide that I try and separate from the students, is that teeth are not simply just a luxury. They're not a nuisance or something that we want to restore. Your oral health is something you actually want to have and actually function with. Okay. The problem is that we have created the medical insurance and dental insurance, even though it's all part of the same body, and people are viewing these more as nice to have than need to have. Things I've heard, I'm too old, my parents have all lost their teeth when they're young, doctors pull them out, or whatever my insurance covers, that's exactly what I want to do. There's no thought anymore. It's because we've created this mindset of a luxury item, okay? It's nice to have, but really it's something you should have. I love this one. Doc, I got the soft teeth, okay? That's the classic. But put this in your mind. If you have a patient who has their foot turned green, would your doctor say, just cut it off? No, you want to treat it. You want to know why their foot's turning green. Okay, so teeth are organs, not just they're not just fun things to have. if you're lucky. We are doctors of dentistry, okay? We're not just simply carpenters. That's what I'm trying to really, teach here. I'm sure you've all heard it, but our patients really don't understand, that why their teeth are so important to them. Factors, of edentulous and what, risk factors, obviously, more prevalent in poorer populations. I'm sure we've all seen that, and then also females. The rate of edentulous is 6 times higher in lower income than higher income families. Other factors, are age over 65, having lower education. That's those people with a less than a high school diploma. Access to dental care. I can tell you today, just right now, I had a patient who came about 2 hours out of town just to see me. She had a canine that was palatal displaced, causing irritation, and the dentist down there said, just pull it. I'm thinking, what? She's 22 years old. She needs that tooth for a while. There's problems with the way that your jaws function. Canines provide guidance. So again, I'm really trying to get this through tonight that we are doctors of dentistry, okay? Obviously, there may not be enough dentists in the population. Their insurance coverage issues, tobacco abuse, alcohol abuse, all lead to factors which could cause edentulism. So the question is, how widespread is edentulism? This article is a really nice one that came back in 2013 in the International Journal of Dentistry, and it looked at a bunch of countries, and it basically looked at patients over age 65 to kind of give an idea of the percent of edentulism. And they found in the United States, right, about 15% of the population is edentulous. If you kind of put that into numbers, if the U.S. population at the time I did this PowerPoint was 328.2 million people, 49 million people are actually edentulous. And that means 15% of your population, which you're treating right now, is edentulous. So that's a big part of your practice. And obviously, if you go to more poorer countries, you get higher prevalence. But that being said, you are seeing these patients in your practice, and it's kind of until I kind of lift the veil, you may not have seen this before, but there's a good chance a good part of your practice right now is edentulous. If you actually look at other studies, it's actually a talking point from the American Academy of Prosthodontists. They estimate that 30% of adults, 65 to 74, are edentulous, even more. Okay, so if I told you that 1/4 of your patients were edentulous, and and they're suffering from this disease, would you want to treat that? Isn't that a health crisis? So symptoms, so remember, we saw, that edentulous is a disease, so what are some of the symptoms, okay? The first thing we always all kind of see is bone loss, all right? Bone loss is a big problem for our patients who don't have teeth. Putting tension on the bone will keep the bone in place. So bone loss will keep on going when teeth are not present, and the earlier it is, or earlier on that you lose teeth in life, the worse it's going to get. There's more time for it to progress. The mandible is 4 times more affected than the maxilla. It causes reduction in height of the alveolus. It brings the muscles and the nerves closer to contact to any kind of denture or the ridge. But it's not only going to be a bone problem, you're also going to have a soft tissue problem. If you look, unfortunately, it's not the best image when it's kind of zoomed up. This is kind of the symphysis region, the perisymph, and the molar area. As time goes on, not only do you lose bone width and height, but look at the quality of the soft tissue. You lose that keratinized tissue as well. So as you try and put a denture on that loose kind of non-connective tissue, you're going to have a harder time to get a denture on there, but also just the area of mastication will be less resilient and therefore have higher prevalence of trauma. If you look at the perisymph area, as we kind of go on through time, the nerve also, that little pesky nerve that we always kind of worry about, the inferior alveolar nerve, gets more and more closer to the surface. Eventually the bone erodes on the roof of the canal, and if it goes on too long, you have that canoe-shaped bone, plus you also have the nerve exposed. So again, putting a denture on that, or even chewing on that, is to be uncomfortable. If you look at the posterior, as you go more of the posterior, but here's the maxilla. As you kind of get more and more away from the alveolar bone, you get more to the basal bone, you get closer to the incisive canal. So again, you're losing bone quality as well as you're losing soft tissue quality. And the biggest problem is on the mandible, I'm sure you all know, is that as you lose more and more bone, it's the mandible where all those muscles connect, and then you try and put a denture on that, and every time they try and articulate or swallow or chew, those muscles activate and push that denture out. So this is a long-term consequence, and as you go further on, down the road, it's harder and harder to treat these patients. So this definitely becomes a disease, not just an aesthetic issue, okay? Here's a little video.
When teeth are lost or removed from the mouth and not replaced, it causes significant changes to the surrounding bone structure, which increases in proportion to the number of teeth missing. Healthy bone is maintained through stimulation provided by the everyday functioning of intact teeth. When a tooth is lost, the bone is resorbed into the body due to lack of activity, causing the surrounding teeth to drift and the bite to be altered. If more teeth are lost, this effect is more pronounced, causing drastic reduction of healthy bone tissue in the jaw. As bone and tooth loss progresses, it alters the structure and appearance of the face due to a decrease in what is called the vertical dimension, the length between the tip of the nose and chin. This can cause premature wrinkling around the mouth, weakening of the facial muscles, and thinning of the lips, ultimately creating the appearance of premature aging. It is important to consult with your doctor to develop a treatment plan unique to your situation that best addresses missing teeth while reducing the potential consequences caused by bone loss. When teeth are lost or removed from the mouth and not replaced, it causes significant changes to the surrounding bone structure, which increases in proportion to the number of teeth missing. Healthy bone is maintained through stimulation provided by the everyday functioning of intact teeth. When a tooth is lost, the bone is resorbed into the body due to lack of activity, causing the surrounding teeth to drift and the bite to be altered. If more teeth are lost, this effect is more pronounced, causing drastic reduction of healthy bone tissue in the jaw. As bone and tooth loss progresses, it alters the structure and appearance of the face.
Hopefully through you guys today. This is a really great article came with the consequences. So mastication in a complete denture is less effective, requiring 7 times the chewing cycle. Imagine you're trying to eat a nice steak. Right? Steak's pretty chewy. You're spending an hour just to chew that one bite. Maybe steak's not going to be as appealing to you. You have to have food cup in smaller portions, okay? The masticatory load of natural teeth is around 500 newtons, all right? The maximum force of a complete denture is between 60 and 80. You're basically, about 15% of your normal chewing force, okay? You must keep in mind that a lot of these studies are done in a way where they exclude other confounding factors like xerostomia. How many elderly patients have xerostomia? Like 90% of them. What's the number one complication of every drug on earth? Xerostomia. What keeps your dentures in? Saliva against the mucosa. So if you start losing that salivary function, your dentures get harder and harder to kind of work with, okay? And as we age, the biggest thing is that our appetite decreases and it's hard to even get, nutrition. So now, not only are you trying to, food itself is so much harder to enjoy, where unfortunately it becomes a health crisis, okay? Again, the biggest thing for me is that all these studies basically were done with newly fitted dentures, okay? Talk to me 2 years later to see how that bite force kind of goes down. So here's the kind of a little chart over here showing natural dentition versus dentures versus locator dentures, where you actually gain much more function, about half what you would with a fixed prosthetic and a fixed hybrid, which basically matches that of like natural teeth, all right? So the impact of edentulous on general health. Well, the idea is you are what you eat, okay? I mentioned to you guys that food is hard to eat. What kind of foods are hard to eat? Carrots, celery, all those healthy things which you should be eating. So a lot of these patients start to eat more processed soft foods, McDonald's, French fries. They're easy to chew, potato chips. So you have to understand that this is a health issue. It really is a problem. As we know, patients who start using dentures, they have lower intakes of fruits and vegetables, they have less fiber, less keratin, and they increase cholesterol and saturated fats. Think about that for a second, okay? Higher prevalence of obesity, obviously because they're eating more fatty, soft foods, and increasing the risk for GI problems as well as cardiovascular problems, heart attack, stroke, okay, Crohn's disease, all those, or sorry, not Crohn's disease, but other diseases of the GI system, okay? We know that we increase rates of chronic inflammatory changes of the gastric mucosa, GERD, all those things, pancreatic cancers, high rates of peptic and duodenal ulcers. You have higher risk of getting diabetes, increase of cardiovascular disease, hypertension, heart failure. I can go on and on and on and on. But the idea here is we all have heard it. This is outside of dentistry. Even our medical doctors say you are what you eat. So if you're not eating carrots and you're eating McDonald's, there's going to be long-term effects of this. So this is a problem. This is a disease we need to treat, okay? We also, as I mentioned, you lose your VDO. Your tongue enlarges to try and fill the space to help you to swallow. So now you're going to see increases in the rates of OSA, or sleep disordered breathing, okay? Your life expectancy is going to drop, all right? We do know that for every single tooth after the age of 70 that you lose, you basically increase your risk of mortality by 4%. So again, you're treating their health. Several studies have established an association between edentulism before the age of 65 and increase of early death. And again, these are things we're not, unfortunately, I'm not hearing a lot from my students talking to their patients about is the health link of what they're actually missing. But there's more than just your, general medical health. There's also, we're all kind of very sensitive about mental health as well. We know it's a disease. We know it's a crisis, right? We were trying, there's big administrations who are trying to talk about this right now. We know that if patients who are in conventional dentures have lower quality of life, they avoid social outings with friends, okay? When you get older, what's the one thing you do? You go out, you eat with your friends, you eat with your family, you enjoy meals, but now you can't enjoy that meal. So you're like, nah, I'll skip tonight because you can't enjoy that steak, right? Your dietary choices are limited. You're more soft foods, which you can kind of gum. They have higher incidence of isolation and depression, less social activity, exercise. They're basically homebodies now, all right? Lack of enjoyment of eating. This came from the Journal of Dentistry in 2009, so this is well known, all right? We also know that even patients who are under 50 have a 1.57 times chance of higher odds for depression, if they are in a complete denture before the age of 50. Those are high numbers. What's interesting is overall, this is from the same article, is just the way that we kind of view edentulism. Once we go past age 50, for some reason, we see, or at least in this, this population, they saw, well, once I'm over 50, teeth are a luxury. If I have them, great. If I don't, too bad, okay? So we see that the idea of depression is also, of course, your own self-health, is that once we get older, we just think that, it's part of life. We lose our teeth. Too bad, so sad. But under age 50, we actually do have some, I guess, constant idea of how valuable teeth are. But again, it's one of those things I'm trying to break, tonight, is that teeth are good. They're not bad. They're good to have for all of your life. Options for edentulous treatment so far are also the dreaded conventional denture, just gumming it. Of course, we have these all-on-4s, or the fixed hybrids. You have locator dentures, or even you can even have these component hybrids. There's lots of options to treat edentulism, and I'm hoping that we kind of can move away from this because of all of the health aspects that we're going to start telling our patients, and move to more of a natural function that'll help increase the livelihoods, the quality of life of our patients. So, as anyone knows me, I'll give you the good, the bad, and the ugly. I'm not going to give you all the plus sides of everything. You got to be honest with your patients all the time, right? So let's talk about fixed or an all-on-4, which we'll talk more about tonight. All-on-4s, they're going to be higher cost in the short term, okay? They're hard to clean. They're stuck to to your patient's mouth. They have to have a commitment to actually keep these clean, brush them, so they actually last a long time. Bad breath if you aren't cleaning these very well. Lack of lip support, which can have an aesthetic issue, which I'll show you later on. Again, they're costly maintenance. You have to replace the screws, and also you have to keep these clean. And every 10 years, you're gonna have to, just like any denture, you should be replacing the teeth. But they are a thinner prosthesis. That's kind of, and also can be a aesthetic challenge. Removable locators, they're tissue-borne. They can move around, okay? They doesn't feel natural. They're going to be bulky, all right? they're still going to need regular maintenance. So you still have to go to your, get those dental cleanings. All right, they can require a palate or thickened palate area, which can lead to taste issues. The inability to sense temperature, as well as can also cause patients to have some gag concerns. Obviously, the bone where the implants aren't, they will still break down and cause it to even fit poor over time. Again, and there is cost when these over time. They're going to have to replace parts, the vinyl inserts, whatnot, and they do have thicker denture bases, which will reduce space for their tongue as well, which can make speech as well difficult. But they are a lower fee short term, and we'll go over that more. What we're talking about today is this idea of a fixed hybrid, which I think is probably the most cost-effective solution out there for fixed prosthesis. Before we kind of go into this, we got to understand, very, 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 very basic mechanics. Okay. What we have is the overhanging beam, and what we really want is the continuous beam, so the support is kind of evenly distributed everywhere. Everyone brought their calculators, right? Good. All right, so what we're going to talk about is, the idea of a fulcrum arm or a load, okay? We'll kind of start off with here where you have your load, you have your fulcrum, and you have your effort. Your load is kind of what you're biting on. The fulcrum is kind of, the point of pivot, and the effort is where the actual force has to be withstood. And it kind of really simply just use this formula so everyone kind of know past, grade 5 math. The reality is, if this is your load, this is your fulcrum, this is your effort, it is really as if W or X becomes, so if W increases or X increases, all right, the amount of effort to stop the load is going to be much higher. But if your length or your effort arm increases, therefore the force will be much more evenly balanced. Okay, so let's just kind of look at this and understand. We have the stereo that obviously we want to decrease this arm and increase this arm. And why does that matter? Well, it's the idea of the cantilever, okay? As mentioned, your effort arm is basically going to be the distance between the two implants, all right? And if you have a long resistance arm and a short effort arm, you're going to put a lot of load to try and counterbalance this chewing force. Because if you have a very long effort arm and a very short resistance arm, this force can be much more easily handled. And that brings us to the idea of what is AP spread, okay? AP spread is very simple. It's just the measurement between a line measure of the center of the most anterior implants and the most posterior implants, right there, a line drawn right through, okay? And the increase in AP spread, basically from A to B, allows you to have a much longer cantilever, okay? Although, there's some studies, by Coopers and Brainemark. Brainemark said it was 2.5 times the AP spread, but his studies were shown actually with a actual complete denture against a fixed hybrid. Therefore, the load's a little different, but it's generally accepted by Dr. English that's about 1.5 times the interfixture distance. Okay. And in general, there's also a rule of thumb where, Linden and Cooper, I say by them, basically show that it was 10 millimeters is really kind of where you should be. But again, either or 1.5 times AP or 10 millimeters is what we kind of normally use. So, the problem is, obviously, we want to increase the AP spread to make sure that we can get, our cantilever even more distal. But the problem is we have the mandibular canals, the mental loop, and the maxillary sinus. So how can we change the AP spread without surgery, okay, without big, huge, nasty grafting and whatnot, is the idea of these tilted implants, okay? The advantage of using the tilted implant concept is obviously we can use longer implants, right, to increase the bone contact, all right? Will actually increase the load distribution. You have a longer implant that not only you aren't just actually loading it up and down, but you actually have a load all across that angle of the implant, which kind of distributes the force along the bone even more, okay? It basically reduces the need for any sinus slips. It reduces the need for any bone grafts, which also reduces the cost for the patient, making a very efficient surgery, okay? So we can actually increase this AP spread by just tilting these implants, which actually makes it easier on our patients. And in fact, if you look at the literature, will also decrease the amount of overall force on these implants because it's spread more evenly across the actual length of the implant, okay? So this is kind of the idea that we put these implants between the anatomy, and we actually want to reduce the resistance arm, being the cantilever, making it as small as we can, okay? A new concept that I came up with myself, last week. This is a very well-known concept. This concept was first, kind of pioneered by Dr. Paul Malo in Brazil back in 1998. So you have about 22 years of good research on this. This is not new. It's something that we've been talking about for a while. So, look at these two guys. How handsome. Both have that, confidence, which is, bearing. So, I can be your Paul Malo, essentially. If you have any questions, I definitely have that same kind of weird angled smile. Or if not, the whole team at Southwest Oral Surgery can, we've all been doing this for a long time. So, like anything else that you add to your practice, this is not going to, like any, even your complete dentures or even your crown and bridge, it's not something which, you used to want to do just for fun. It's something that you ought to be committed to, a tool that you want to add to your practice. So it's not going to be something I say just do just for the heck of it. Do it because you want to do it. You actually want to try and add some new, technique or a new armamentarium to your practice. Because again, this is a large commitment between you and your patient, okay? You have to be prepared to see the more appointments than you really want to, especially when, your first few cases. That being said, you have me, you have Tramian and Jason who would love to be, kind of walk you through this, but once you start doing it and you kind of get used to it, it really isn't that bad at all. It's like anything else. It's like your conventional denture or your crown and bridge. Once you get good at it, it takes a few times to get comfortable. Once you do it, it really is not that bad. There will be mistakes. I didn't, none of you got to where you are by not having problems. The best teaching moments are when you mess up or when there's a problem. But you know what? You learn from it, and therefore, if it happens again, you fix it. It's not that bad. Obviously, there's also going to be some emergency visits if things break. Again, don't freak out. You give me a call, you give Jason a call, give Trim a call, we'll walk you through it. I've seen it, I've done it. It's not that bad. No one's dying from this, all right? They're gonna be fine, I promise you. Patients will say a few things to you, right? Well, for the amount of money I paid, I think it should be perfect. Don't you? So there's some things you have to expect, They're gonna say, this is a high-priced item, they're gonna say all these kind of weird things, we're not growing natural teeth here because it takes a little time. It takes a few appointments which Tramian will kind of go through with you, okay? I want it done perfect and I want it done fast. This is my biggest gripe because you see all these clear choice ads, how like it's teeth in a day. How many times have you heard, hey doc, why can't you do teeth in a day? Because if it's too good to be true, it's too good to be true. It's just that simple. You want to measure 3 times, cut once, all right? You have to have realistic expectations, and this could be a red flag that maybe that's not the patient you want to work on, all right? You don't have to say yes to everybody. I thought it was meant to be done in 1 day. Well, no, that's wonderful. Nobody told me this could break. They're coming in with a high-priced BMW, and they're paying $80,000 for it. And I'm sure they knew there's going to be maintenance. Nothing is maintenance free, and that's another problem with which I've seen with some of the clear choice patients who come to me. They haven't been really taking care of their teeth for X amount of years. All of a sudden they're going to be the greatest patients on earth. No, they have to understand there's maintenance. There's wear and tear. This is a mechanical thing, right? I thought it was last me forever. Nothing lasts forever. So again, you got to make sure that that we kind of let our patients know realistic expectations and that the commercials may not be exactly true. Okay, make sure you talk about improved chewing ability, improved confidence. There's no palate, which is everyone hates when they get dentures, right? It'll feel like real teeth. You can't have new teeth on the same day if you offer immediate loading. You don't always have to load, the teeth in 1 day. Okay, there is going to be some, financial commitment they have to understand. Healing from surgery takes time. They're not going to walk out tomorrow and start, playing, ice hockey. Okay, it will take some time to get used to speaking with them. All right. There are, just like with dentures, it takes time to kind of get used to this new, tongue area, all right? And there will be maintenance visits, and that's the key. There will be maintenance. They will come see you every 6 months to get cleanings. They will have to have the denture clean. They can't just go home and never see you again. They're going to be your patient's lifetime. All right, it takes a few appointments to get this done. Again, teeth in a day, never heard of it, okay? Even when I do immediate crowns in a day or temporary crowns, it takes time to get these done, all right? Again, it's going to be challenging, to clean under these. They're going to maybe get a water pick. They're going to use super floss. They're going to have to keep these clean, and it's a little hard to kind of, get these items under there. So one thing to consider, if they have RA, if they have really bad dexterity, this may not be for them. Okay, the gums are going to look strange during the healing period. Okay, the gums are going to recede when you're actually healing. All that swelling is going to go down. And you're going to see the space between the gums and the actual denture increase over time. All right, they will need some time off of work. This is a surgery. So why is screw retained all on four? Obviously they're implant born, they're not tissue born, therefore the implants take all the loads, all right? You're gonna have the same biting force as they would have natural teeth, which is they increase their life expectancy, increase their quality of mastication, and their outings out, okay? They cannot be removed. They're not going to be on the side of their bed, all right? There's going to be no flange on the prosthesis. It'll be a very thin, just over the actual ridge. It won't feel like there's this bulky thing in your mouth. There's no palatal on the prosthetic. Okay, their tongues have space to kind of function in. They're not going to feel as though they're kind of, crowding in their own mouth. More natural feel. It's a high initial cost. Again, when you actually do, but then there's a low cost lifetime plus all the medical bills that they're going to save when they're actually eating right. Avoids the need for any grafting. Again, avoids the risk of the anatomy, high patient satisfaction. Once they do this, they're going to show off. They're going to tell their friends, this is a kind of a status symbol when you have an all on four. They will tell, Dr. So-and-so did this for me. They're not going to hide it. They're going to say, look at this is amazing, right? Again, things which I like to always kind of stress when it comes to your patient's needs to hear, it's not a final prosthesis in one day. They're going to get a temporary denture in a day, which will screw in. Okay, you may not always be able to load this temporary denture. If the bone is so soft, sometimes we let it kind of heal up and then come back later and put on the actual denture or the temporary denture. Again, the biggest thing for me is they have to understand they're going to have regular cleanings. Those implants need to be maintained just like natural teeth. All right, there's going to be mechanical failures, just like dentures. If they're going to have fractures, teeth are going to fracture off. There's be wear and tear on them. Okay, like every denture, every 10 years, they're going to have a new denture or refabrication of the actual bar. So they're actually going to have every 10 years, on average, to have these teeth remade. All right.
Yeah, and they're not natural teeth. There's gonna be a little bit of change in the feeling. There's no PDL. There's no PDL ligament, and there are limits to what we can do. If their jaw is very thin, very narrow, and you can't get the AP spray, they may only get up to premolar height. This is kind of the challenge that I always kind of point out is the hygiene challenge, and this is what I always stress to every patient who comes to my office for a consult. The interior of their teeth. Then, if they're going to invest this kind of money, they have to start taking care of their teeth now, even though that they're implants. You can see all that kind of gunk on the bottom of that denture or the prosthesis, those red gums. You can only imagine how those implants kind of are handling that stress. There's a video that actually show
kind of explaining how they maintain their dentures every day. They're brushing their teeth every day. They're maintaining this every day. And that's why you also want to make sure that when you have these patients, you select for someone who shows commitment. It's something they actually want to do, because if their implants start failing, they're going to start coming back to us and say, well, hey, I paid all this money. Well, again, if you drive your car 100 miles an hour and brake hard every day, it's going to break down a little earlier. But they're still brushing these, prosthesis. And that they kind of have to get used to that. So we've all heard of clear choice. So why would a general practitioner want to do these? Obviously, if there's places like Clear Choice that specialize in them. Well, first of all, these are your patients. Okay, these are patients who you've known forever. They trust you. Like any DSO. First of all, Clear Choice, their surgeons are not even in St. Louis. Okay, their surgeons in Kansas City and back around here in the world. So if there's a problem, no one's really there to help them. So the difference between us and a DSO is that if something happens, we're going to be there for them. Okay. Their price is higher than ours probably, all right? Even though they do a lot of them, they have a lot more overhead of marketers and crazy commercials and all those things. So we actually can give them at a reasonable price. Again, the long-term patient care, again, we have the hygienists, we have the stuff to actually treat these patients, for their everyday needs. Obviously, we have much more experience, in my mind, just treating the everyday dental needs than a doctor who's coming and going every year. Okay, obviously, the quality of work, in my mind, we're not, because we're going to see them forever. We're not going to cut corners. We want to do the right thing for them because they're going to come back to us. All right. And again, the biggest thing is these are our patients, and Clear Choice has done anything. They've shown us that this can be done. But I think the difference between us and a DSO is that we're going to be here for a very long time. These are our patients, and we actually care to do a good job long term than kind of run it out of town in a year. So some key points before I kind of pass it off to Jason. One thing you have to understand when it comes to a all-on-4 versus a conventional denture is that there's be some bad is lip support. Because these are very thin prosthetics, a class 2 or class 3 patient may not be the best for this procedure. As you can see, because it's so thin, there's be no paddle, no flange, and no lip support. So you see this patient with a conventional denture in place and not in place. You can see that lip support may be better in a conventional denture, using a conventional denture than all-on-4. And obviously, the biggest thing is reduction is going to be the key, all right? And I'll kind of explain this in a second, these slides where I kind of wanted to point out before I passed on. But the reason why this is a much more sensitive surgery is that it's not simply putting an implant. You actually have to make sure that your lip line is matching up with the CJs of these teeth. So you actually have to reduce the bone accordingly, okay? One question I get commonly asked is 4 or 6 implants. Well, the reality is that we went over the idea of AP spread. Really, as long as you have a good AP spread, the force should be distributed enough where it shouldn't matter. And the only time you actually may want to put 6 versus 4 is maybe going to be when the bone quality is not there because you're worried about the bone failing or the bone fracturing because there's too much force. Usually you're going to see this in male patients, those who have opposing natural dentition or very low bone density. Again, 4 or 6 doesn't matter. The reality is, as long as you have the AP spread, it's going to be fine. I'm going to give this off to Jason for a few moments, but is there any questions so far on any of this? Yes, Mike.
I'm just curious, a lot of these patients that go for the all-on-4, are these repeat edentulous patients like they've been a conventional denture before?
No, honest to God, they're not.
They'll go for that.
And then they're not first of all, they're not all your patients from Ladue and Frontenac. They're your patients who've really who've been suffering from this disease for a long, long time and are fed up. They want to change. Okay, those are the patients who I see. They're usually just unfortunately very poor dentition, a lot of dental caries, and they're suffering. And they're usually younger patients, probably in their 40s, 50s, that unfortunately have not been able to chew in a while. And they want to change that. So they've made that mental switch to, hey, I'm suffering. I want to get this treated now. So again, Jason will kind of go more into this, but yes, they're actually patients normally who have bad teeth, who just realize that they don't like the way it looks, and again, they're more probably out of that era where, under 50, where the idea of having natural or having dentition is a good thing in their mind. Is like they feel as though it's a problem. But as we get older, for some reason, our mindset is teeth are a luxury. Like, they're there. So usually they're in their 40s, 50s. But yes, I'm gonna let Jason is there any other questions? No? All right, I'll let Jason kind of go on here and let him do his little thing.
10 to 15% of the patients we treat are edentulous. It's almost always, some are
It,
either have bone or money. Never both.
yeah, I will I like the term the normal market, and I'm going to use that term tonight, normal market. What I mean by that is we've got a general dentist here at 123 Elm Street. We've got an oral surgeon over at 456 Russell Street, and we've got a lab over at 789 Joe Street. That's generally how the normal market has been in dentistry. Now there's a lot more total service providers out there now that have everything under one roof. But what can we do in the normal market to help reach more of these cases? So right off the bat, if I was to ask you, what's the main reason we don't do a lot of these? What's everybody going to say? Cost. No doubt about it. And there's no way I'm going to sit here and say, guess what? Tonight we've cut the price in half. That's not going to happen. They're always going to be viewed as expensive. No doubt about it. Not many people have $25,000 cash sitting in their glove compartment of their car. They're cumbersome, complicated, on and on and on. They do take a while. There's a lot of steps, so on and so forth. We're going to get into the steps tonight in a little bit more detail. But that is something that we can overcome. So what we put together was, and really, I don't know how long ago we started this, but I probably had a conversation with Dr. Hash, I'm guessing 8 or 10 years ago on, hey, we've got to be able to come up with a marketable product for your referring doctors so that they don't look at these cases as expensive, cumbersome, complicated, and so on and so forth, so that your referring doctors have confidence in talking to the patients when they come in, those patients in need of these, so that they can market them. So we had to come up with a streamlined procedure. I won't spend a whole lot of time on that. It has to be cost effective. Are we in the normal market able to beat Clear Choice or affordable dentures in price? Generally, we can beat them by a little bit. We're not going to beat them by a whole lot. But I'll go over a sample scenario of what these full arch cases cost back in the day. So something more cost effective, something that has to be done in a timely manner. Yes, we offer teeth in a day, not the final teeth. Okay, that is the big trigger point, the big trigger point at these implant centers. Yeah, Joey, you're leaving with teeth today. Remember, the vast majority of these patients that do these cases are scared to death to go into dentures. They do not want to be without teeth. That is, so the teeth in a day is a huge selling point. And you see that on Clear Choice's commercials. That's something they really hammer on at their practice. Obviously, if they're going to spend that kind of money, they want it to look good and they want it to work well. So we've got the all-on-4. So what generally happens in the normal market? I'm probably going to spend about 10 minutes on this slide. A patient will see an affordable dentures commercial. And they come into Dr. Singer's office. I'm not going to use anybody in here because I know you guys know what to do. But let's say they came into a general dentist's office. Hey, Dr. Joe, I saw this implant commercial. Can you do those screw thingies that I saw on TV? And in the vast majority of times, that restorative doctor has not restored an all-on-4. We saw that just by the number of hands that were raised in this room. The vast majority of times, we have not done one. In fear of losing the patient, but yeah, Joey, we can do those. I don't know exactly what the next question is going to be, but most of the times it's going to be, okay, what's it going to cost? How does it work? Is most likely probably what the next questions are going to be. And the vast majority of the times, the restorative doctors are like, well, I'm going to have to get back to you. We're going to have to talk with the surgeon, we're going to have to talk with the lab, so on and so forth. So I will get back to you. Joey leaves the office. Dr. P calls the lab, very first question, hey, Bill, I got one of those all-on-4s. I don't know what I'm getting myself into. What's my lab bill? Okay? The next movement that happens is the doctor picking the phone up off the floor. He's like, whoa, hold on. Let me clear my ears out. Repeat that again, because some of these lab bills, depending on what we're doing, can be extremely expensive. Okay? So that restorative doctor may already be a little bit hesitant. They may, okay, that lab bill is $4,000 to $5,000, because that may be the range that they're going to get. It could be $4,000 or $5,000, doc. I don't know. What do you need? What do you need us to do? Do you need a conversion, duplicate dentures, bone reduction guides, so on and so forth? A lot of restorative doctors, oh man, hold on. Let me think about this. And they may sit there over the next week, think about it, and then decide, all right, I'm gonna call Joey back. And all right, Joey, yeah, we can do those. My fee is going to be, and it's whatever. A lot of times we'll take a multiplier to a lab bill. So they may say my fee is going to be, I don't know, anywhere from 10 to 18,000. It depends. Well, what does it depend on? Well, I don't know. The lab said it kind of depends. So here's a few specialists I want you to go see. Okay, so that restorative doctor may give Joey three specialists. So Joey may go see ABC oral surgery 1 week. ABC oral surgery may say, all right, we're going to do this, this, and this. This type of graft, we're going to put in 8 implants, we're going to do so on and so forth. The following week, they may go see a periodontist, says, I'm going to do that, that, and that. And they may do 4, so their solution. And they may go see somebody else and get something else. Okay, so they spent a few weeks driving around town, seeing specialists, and a lot of times there's going to be different game plans and there's going to be different costs. So the patient comes home, so a month later he gets the calculator. I was like, boy, there's a lot of different figures out there. Nobody had a definitive answer. And it looks like it could be anywhere from 25 to 40,000. It kind of depends. That happens a lot. Now, that doesn't happen as much these days, but I will tell you 5 to 10 years ago, that happened quite a bit. And these implant centers kind of saw the problem in the market. And I'll tell you, like ClearChoice started, the guys who started ClearChoice were the ones that started the LASIK centers. And so they found a well-oiled machine in that business and like, okay, we can do the same thing in dentistry because there's a lot of patients that need these big expensive cases that are falling through the cracks because of those issues. And it's a lot of it is the fear of the unknown. We know there's a large number of restorative offices who haven't done these. So there's a lot of, hey, do I have the right tools? Do I have the right impression copings? Do I have this? Do I have that? And after a while, a lot of times they take the case and punt it. Joey, go see ClearChoice. They do 5 cases a day. And like Dr. Reddy brought up, I probably sat in 400 surgeries at ClearChoice alone for about 2 years. I was there almost every day. Those patients, like he said, are not from Ladue and Frontenac. That's a guarantee. That's not me saying I don't think. That's a guarantee. Patients are not, the cases that we're treatment planning here in St. Louis, they're not hedge fund managers coming in from New York. That's a guarantee. We are not the implant mecca. They're not actors from Hollywood. They're all local folks. So yes, it's expensive. There is no doubt about it. And it's still a small percentage of people who can afford these. But it's happening. It's happening every day. And we know that because of like those 3 businesses that I showed you. And they're all very successful. So there's no reason you guys can't be just as successful as those other businesses. So that's why we kind of put together what we are calling the TEM, or our treatment efficiency model. And that's why we have the surgeons in the room with us and doing this at a lab, because this model, it's a business model. And it's designed to help you guys act like a ClearChoice. Okay? The very first thing that this model does, it gives us the ability to come up with a predetermined price. And that's the real big thing, is patients, they want to know, okay, what's it going to cost? And they don't want to have to drive around for 4 weeks and then get the calculator out at the very end and say, man, it looks like it's anywhere from 25 to 35,000. I heard a lot of, it depends. Because that does happen, okay? There's no doubt that happens. So what we did, and actually this treatment efficiency model was started by a couple implant reps down in Texas. probably about, well, I don't know how long, before Clear Choice, but I want to say 10 years ago, 12 years ago, we started implementing it here in St. Louis 8 to 10 years ago. So I sat down with Dr. Hosh probably 9 or 10 years ago and say, Doc, we got to start coming up with surgical fees, a surgical fee, okay? Whether you have to extract 12 teeth or no teeth, whether you have to reduce 8 millimeters of bone or no bone, whether you have to use this much anesthesia or that much, so on and so forth. Because what we don't want to do is when Joey comes in after seeing the Clear Choice commercial is give him a list of pricing. Because when they go to Clear Choice and they sit down with their professional sales rep, every question is being answered. Here's a demo model, here's a patient testimonial, here's our financing, here's how much it cost, here's this, here's that. They're all being answered right off the bat. So the very first thing I sat down with Dr. Hosh and said, look, we got to have a more marketable product for these fixed full arch cases, and we got to come up with one cost. And because we know, and we've seen this, and Dr. Reddy, we just did a case last week, we know, yeah, we're doing one tomorrow. On average, if we see 100 full arch cases, we're probably going to be extracting 6.3 teeth, reducing 4.2 millimeters of bone, placing 4.375 implants, blah, blah, blah. Where I'm going with that is we take a law of averages. Obviously, he's going to make more on a case where the patient's fully edentulous and it's a cakewalk, and less when he's got to yank out 12 teeth and cut down a whole bunch of bones, so on and so forth. But we were able to kind of take our law of averages and come up with one surgical fee. Okay, no matter who. Now I will say, okay, if the patient has 0 bone and they got to do a hip graft and go to the OR and do zygomas and so on and so forth, that's a different story. But we've done a bunch at Southwest Oral Surgeon. We've never, I don't know, have we ever punted on a patient that we never had to say, hey, we're going to throw you in some zygomas. Generally, we can get them done. Okay, so we come up with that surgical fee. So the very next thing was, as I sat down with Dr. Hosh and said, all right, look, remember, not a lot of the restorative doctors you work with have done these, and they may not have all the armamentarium they need, so I want you to buy everything. And he kind of looks at me like, what the hell? I want you to buy everything, doc, so I need you to buy the implants, the final abutments, the temporary copings, the healing abutments, the healing caps, so on and so forth. Because what we want to do is make you, the referring doctors, working within your comfort zone. And your comfort zone is your chair time. You know what you need to charge per hour for chair time to pay the bills and to pay yourself your salary. So we came up with our surgical fee. And then I put an Excel spreadsheet together and said, all right, doc, on average, remember, we're probably going to be placing 4.375 implants per case. Because on uppers, sometimes we may put in 5, so on and so forth. So then he has an all-inclusive equipment fee that he's going to be getting a bill from Nobel Biocare for. So he's like, okay, well, I got my surgical fee, that one surgical fee. I know what all the equipment's going to cost me. All right, Jason, I'm ready to go. Let's market to the referring docs. I said, all right, here's the next thing. And I would generally get weird looks when I tell the surgeons this. Doc, I want you to pay the lab bill. Dr. Hosh, I want you to pay the lab bill, not the entire lab bill.
I wanted Jason to pay it.
Yeah, and he's like, and then he politely asked me to leave after he hit me, because remember, we want the referring doctors to be concerned with what you're most comfortable with, which is your chair time. Because here's the thing: there's a lot of variables in these lab bills. Because he doesn't know, he may want a bone reduction guide, or a duplicate denture, a lot of things. Okay, so they begrudgingly said, all right, yeah, I'll pay the lab bill. That lab bill is going to include a new denture. It's going to include the final. It's going to include impression coping, so on and so forth. Okay, so we came up with our surgical fee. Then we added on all the equipment on top of that. Then we added on the entire lab bill. Okay, so that now is their all-inclusive fee to treatment plan one of these fixed full arch cases. I'm seeing some squinty look. Is that all making sense so far? And so let me take one step back. This is just one way of doing this. If you go, heck no, I want to pay my own lab bills, I want to buy my own stuff, by all means, go for it. That is no problem. They would be like, hey, you can do the conversion at your office. But that is how we do a lot of these, the vast majority of these cases. I won't go over specific figures tonight, but let's just say their all-inclusive bill may be around, let's just call it around $18,000. 18,500. We know Clear Choice is around, what, 25, 26, 27. So then you're all probably sitting there going, all right, Jason, we're general dentists. Where do we fit in? If they're paying for everything, doing everything, this is my patient. What the heck's going on here? Are you stealing our patients? No, you guys have to restore the case. So there's a lot of involvement. There's a little bit of involvement prior to the surgery, and then a lot of involvement post-surgical. All right, we'll get into that in a bit, and Tremaine's going to go over that in depth here shortly, and I guess I better start talking a little faster. Does that make sense, how I came up with a predetermined price? Because that is very critical. When that patient comes to your office and says, hey, I was just down the street over in Creve Coeur at Clear Choice, can you guys do those? Yeah, Joey, we do them for blah, 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 and we'll go over that in a little bit. So the TEM alleviates you don't have to worry about the lab fee, so I don't even know why I have that in there anymore. Function like a total service provider, that teeth in a day solution. I can't guarantee, Dr. Reddy can't guarantee, Dr. Wade can't guarantee that they're going to have teeth in a day, just like Clear Choice can't guarantee it. If that patient's bone is like a marshmallow, we're not going to be able to load it. But the vast majority of cases, we can do it. But you most certainly are going to market like a Clear Choice, like the affordable dentures, that yes, we offer teeth in a day solution. But you always have to tell the patient, before they leave, hey, there is a possibility that we might not be able to load it, but we've got I don't even know, I'm going to guess with Southwest, we probably have a 98% success rate of being able to load the teeth that day. I can't even think of the last time we sent a patient out without loading it. But that is key, because that is a big, big market. We're Americans. Everybody wants it quicker, faster, stronger now. Now. We're very needy. We're a very entitled society, that's for sure. Streamline procedure, we'll kind of fly through that. Take advantage of the market awareness. Remember, they spend $250,000 a month in advertising. That's free advertising for you all. Because your patients, you've been seeing them forever. They don't want to go to somebody new they don't know. They'd rather see you guys. Okay? Well, now, hopefully after tonight and after we think about these things and let them stew, we're going to be able to market those patients in the exact same manner as these total service providers. One thing, too, this is a dynamic model, and where I'm going with that is some of the stuff I may say right now, Tremaine may say, you know what, we're doing it a little bit differently now. Because the labs, the rubber meets the road at the laboratory a lot on these big cases. And a lot of times they're improving their techniques. Sometimes we can alleviate one step, we can improve one step, so on and so forth. And I also say this is a dynamic model because you can really do what the heck you want with it. We just came up with it so that these cases were more marketable. But like I said, if you, the restorative doctor, want to do your own conversions, does everybody know what I mean when I say conversion? And Tremaine will talk about that in a little bit. I'm missing. Well, anyhow, so you're all probably like, all right, Jason, now this is our patient. Where do we fit in? All right, what is our involvement? Now, I'm not going to spend a whole lot of time on this, and I'll kind of fly through this because Tremaine's going to go over this a little bit more in depth. Let's call these about 6 points of interest, okay, when you're doing one of these fixed full arch cases. We know we have a predetermined price. What I want you to do on this, and what Tremaine's going to go over in depth with you, is I want you to think about, okay, how much time is that going to take me? Okay, because then I want you to think how much you want to charge based off how much time that's going to take you. Pre-surgically, we're going to make new dentures. Whether the patient has good dentures or not, or if they're in dentures, we're going to make new ones a little bit stronger, maybe a little bit thicker. Tremaine will go over that in a little bit. But that denture we're going to use to make a conversion to be a screw-retained temporary. Remember that teeth in a day? That's what the patient's going to be walking out with that day. So we got our denture setups. You're going to have a post-op check. Dr. Waite may do the surgery on Monday. You may say, I'm going to see you the following Monday. This post-op check doesn't have to be a real long appointment. You know, and it depends. I've sat in on 1 million all-on-4 lectures, and a lot of these guys that get up there and beat their chest, oh, hell, these post-op appointments, I don't care. I just flatten out the occlusion. That patient shouldn't be eating anything but, you know, soft diet for a while anyway. Let's dial in. Let's get the occlusion the best we can. But really, you just want to take a look at the temporary and make sure you kind of like what's going on with it, okay? Because that is going to be a roadmap to our final. And plus, that patient's going to get a little addicted to that temporary. Remember, they've been eating with 6 stragglers, barely eating, I should say, and then all of a sudden they get these beautiful temporaries. They're going to fall in love with them. And we're generally going to follow the lead with those temporaries and making that final. So the post-op check is just to make sure you like what's going on. Next thing, we're going to be doing some type of abutment level impressions, then some type of trying, another type of try-in. Tremaine will go over this a little bit, and then our final delivery, okay? So here's appointment number 1, new dentures, okay, immediate dentures, all right? Post-op, let's just make sure we like what's going on, okay? Abutment level impressions. Tremaine may say, no, we send you an impression jig. I don't know, he'll go over that. But we got to do something verified because the bar we're going to make doesn't move. So your impression has to be verified. So here's just a sample of a verified impression that we may do. The patient comes in, you unscrew the temporary, and we screw in like a custom impression jig. They all get luted together. We take our impression with an open tray. You have to use an open tray for these all-on-4s. You have to, because sometimes the angles aren't perfect. Now that's changed, but I don't know if that'll have a whole lot of time to get into that. So you do an open tray, so on and so forth. The next, we got some type of try-in, wax teeth try-in, a bar try-in, so I'll let Tremaine go over that. And then another try-in, a change appointment, and then our final delivery. But let's call it 6 points of interest. It may be 5, it may be 7. Your post-op check may be 15 minutes. Your abutment level impression may be an hour and a half. Generally, we tell people you're probably going to have 5 hours, 6 hours into it. Okay, and generally, if you want to be billing out at whatever, let's say $400 an hour. Hey, this is a big case, double it, make it $800. You know what? The heck with it. Let's make it $1,000 an hour. Charge $5,000 or $6,000. Because if Dr. Waite said, hey, I'm going to do everything for $18,500, and you're $5,500, or let's say you're $5,500, is a lot of math I wanted to Vianney, whatever that is, I think it's like $23,000 or $24,000, then that's what your case fee is. Okay, so when the patient comes in and says, hey, I saw this Clear Choice commercial, you know, can you do these? Absolutely, Joe, I do them. I do them with Dr. Reddy. We do them for $24,500. Here's a demo model. Here's this, here's that. So now you're acting like Clear Choice. Okay, so that's what the treatment efficiency model is. I flew through that kind of quick because I had limited time tonight, but does that all make sense? Everybody feel pretty good? I'm going to go, the procedure that we use on these is the all-on-4. We don't have to go over it. The benefits of it, Dr. Reddy went over that.
It's a little slow.
The implants that we use for this, 99.99999% of the cases are these Nobel Actives. Because remember, we sell that case that, hey, Joey, you're leaving with teeth today. So those implants got to be anchored in there, and got to be anchored in there tight. So I just show this slide to give you an example of what a Nobel Active thread pattern looks like compared to
The video.
oh, shoot. I'm going to skip this. We don't have enough time for that either.
You know, they're going to floss around. These implants are use super floss. They can use water picks. But again, over time, food and gunk is going to build up on these abutments. It gets better, I promise you. There we go. There's a floss finally. But again, they have to be shown that these need to be clean. If they have bad habits now, they got to get those good habits in. Interdental brushes, they can use that. Flossers, everything. So they're going to have to start taking care of these, especially if they're putting that kind of investment.
facial muscles, and thinning of the lips, ultimately creating the appearance of premature aging. It is important to consult with your doctor to develop a treatment plan unique to your situation that best addresses missing teeth while reducing the potential consequences caused by bone loss.
So one thing I do want to point out here is that people may not have always thought about, but even when you lose a single tooth, it's not only affecting that one area of the ridge, you're also affecting the tooth next to it, okay? So you're actually getting recession of the teeth adjacent to the area of the lost tooth, also compromising its long-term lifespan and its longevity. In addition, as your muscles,
Here's a Nobel Active compared to one of our traditional thread patterns. So you can tell right off the bat, and you can't even see the apex of that active where it's even more aggressive. Which implant do you think is going to dig into that bone better? Okay, the active. Because remember, we're telling Grandma Betty, hey, you're going to be leaving with teeth today. We hope. We want our best shot of doing that. So that's why these guys use the Nobel Active when placing these in.
your teeth go away, your muscles are no longer
When abutment
functional.
you all are restoring from the abutment level up in these fixed full arch cases. Everything is from on top of here, okay?
Way that they should
And I'm gonna just probably skip through a lot of this. So
function.
I'm running way behind.
You're having higher prevalence of myalgias, TMD, overclosure. So there's a lot of consequences with tooth loss. So we really want to restore function as well as overall health. And that's what I'm kind of we do, the vast majority of these cases in the past were restored with what we call a hybrid, which was a titanium bar wrapped in acrylic with denture teeth processed in it. Like Dr. Reddy said, those are denture teeth. They're going to wear, especially depending what they're opposing. Things are changing. We've got new materials, new products. We're doing all zirconia bridges. We just now launched an all zirconia bridge that actually has the angled screw channel technology built into it. You're like, okay, big deal. That really only matters on my anterior cases, when I got to kick that screw access channel lingual. The nice thing about this is, when Dr. Hash is doing some of these cases and he's got to angle those implants at a crazy angle because that's the only bone he's got, we put a 30-degree abutment on there to bring it back to hopefully a restorable platform. But sometimes that 30-degree abutment still doesn't even land us in a good spot that's easy for you, the restorative doctors, to access. Okay, so now we've got this angled screw channel technology, which gives the lab the ability for you to come in at up to a 25-degree angle on restoring these. Why do you care? Because at 6 months, when you go to take this final prosthesis off, it'd be real nice if that screw access hole was coming right out the occlusal plane. It was easy for you to get to. We want to, does that make sense? Because you're going to be doing maintenance on these. So you need to take these on and off.
It may be every 6 months, it may be every 9 months, maybe once a year. It really depends on the patient. And I get that question a lot. Hey, Jason, how often should I do it? I don't know. Depends on Grandma Betty, how well she takes care of it. But with this new technology, it really makes accessing those screws a lot easier. I've gone too long. Does everything I kind of said make sense as far as putting together that business model so that us, the normal market, can approach these big fixed full arch cases the same way as these total service providers? Yeah.
I was just going to point out, and I think one of the keys to this for us to have success, for you guys to have success, is to make sure that your staff members are aware. Yes, we can.
What we do in order to get ready for an all-on-4 and how we actually do it. These are the patients you're going to see. Peri-involved, multiple caries. You know, they're trying to save their teeth, but you know it's kind of not the best case to kind of restore with individual crowns. So the first thing you have to understand is that, you know, this is I'm going to give you two examples of an up and arch. If you kind of see just how far these sciences kind of go, and you know, as I kind of mentioned, the first step that we do is we take out the actual teeth themselves, and we want to reduce the actual bone. As I showed you in my previous slides, if you just put your implants in here, when you put all the prosthetics on top of the implants, you're going to have this prosthesis, which is kind of dangling below the actual lip line. They're going to see all the metal pieces. It even cause too much or increase in their video. The first step is we actually edentulate the patient. Using a guide, we actually mark the area of how much has to be reduced. Again, a lot of patients have periodontal disease, a lot of bone loss. So in this case, really not that much bone had to be removed. Then section all the bone to be about 15 millimeters measured from the incisal edge from the actual opposing arch, so we can get all of that room in there. So actually, we'll kind of just take a big sagittal saw and just kind of zip it right off, and we'll create that space. We'll place the implants themselves, okay? And then again, because this is an older case where I kind of put the implants where I felt the best bone that I can reach. But what goes on top of these implants are these multi-unit abutments, which help bring the prosthetic surface even palatally, so it actually will come through the palatal cusp. And then we have this little guide which kind of showed me to make sure that my abutments were angled more palatal and therefore won't exit through the facial. Then we put on kind of just these little abutments which kind of help us suture things up. Then with the lab, we will then start converting the actual denture. So in our office, we do the surgery. We actually do the conversion while they're there, while they're comfortable, while they're asleep. So when Jason was saying conversion, he actually meant we actually put that denture in the same day for them. So it's a long day for them. They're there probably from 7 till 12 or 1 o'clock in the afternoon. And as you can see, she's smiling, she's happy, her denture is in. When it comes to post-op, again, these are denture teeth in a day, to be honest. And again, they're still healing underneath. They're still going to be on a very soft diet for 2 months, rinsing after every meal. When it comes to comfort level, normally, my patients are getting Marcaine plus Experl afterwards. So they're actually pretty comfortable for the first 3 days. Also, I usually mix mine with PRGF or PRP, and patients tend to have, a pretty comfortable experience. Post-op, this is done by hand. We can see we have 4 implants in. We kind of always want to kind of skirt the sinus. We kind of just got through just on a little edge of the sinus over here. Not a big deal. We know that we can be 2 millimeters in the sinus without any kind of long-term complications. And again, she'll probably come back for her lower denture down the road. Now, today we do it a little differently, okay? Now with the help of technology, everything's guided. Everything's simple. Everything's easy. Using Keller Lab, I've made this so much easier for me. The surgeries are shorter, and I'm guaranteed really good results. Using guides, we plan the size of the implants, the placement of the implants, the reduction guides. So everything is purely digital. As you can see, they'll tell me exactly where to place these implants and how long they are. So we're guaranteed a perfect angulation afterwards. They'll even tell me the multi-unit which I should use in order to make sure that it comes through in a prosthetically pleasing area. This is kind of an example. We actually did this a few weeks ago where we actually have the guide kind of pinned on in after we take out the teeth. It's kind of pinned on in, can't move. Literally the implants are it zip. It literally is cut by numbers. There's final result. AP spread's perfect. Okay, the upper and lower all on 4 here. In this case, she had enough reduction. These actually could be straight. I was doing this with a prosthetist who actually likes to do their own conversion later on. They actually don't want to do the conversion that day, so you don't always have to convert the same day. You know, if you know, it could save a little lab cost as well. But again, you know, this is the latest and greatest. When they come to our office, everything's pre-planned. This is why it takes a little time to work out. That's why it's not teeth that day when they come in, but there's planning. We're measuring before we cut. Again, any questions on this, the surgery, or what the needs are, or post-op questions that they might have? And again, this isn't as bad as it looks. A lot of them are getting Exparel, PRGF. They're healing super fast, super easy, and they're pretty comfortable. The biggest thing is a soft diet for about 2 months because these implants are still healing. I normally have them go see the restoring doctor, you know, 24 hours later just to adjust the occlusion. I will adjust the occlusion myself, but I'm not the best at it. I kind of just play around with the articulate paper and the burr and kind of just do things by eye. But again, they come see you afterwards, you know, just to kind of make sure, you know, they're happy, you know, give you any grievances, and you kind of perfect the occlusion, and they kind of see me for, a week later, a month later, then 4 months. I usually check these implants, make sure they're all nice and tight, and then we get you back to the next step, which is the actual final prosthesis. So it really isn't that bad, and they're asleep, you know, through the whole thing. So they wake up and, you know, they're actually amazed because like now they've gone from, you know, having really poor teeth to nice teeth, and it's a big, you know, jump in their life. And I've gotten more hugs right after than I think any other procedure I've ever done because they want this. I'll hand the mic over to this young man who makes it all happen. He makes my job so much easier, and I can't thank him enough for it.
It's nice with this kind of mic. See, I don't have to bend it down like I would if something. My name's Tremaine. I'm the training manager here at the dental laboratory, and we're going to talk about the actual, basically 2 phases that you guys are involved in: getting ready for the surgery, making the teeth that would be the teeth in a day, and then what we'll do at the final restoration.
Implants.
All right, so first we want to prepare for the surgery. A lot of times we're going to be starting out with making an immediate denture, which will be the actual prosthetic. A lot of times when some of the single place providers talk about it as a bridge, and I think that can be a good way to present it to your patients, even though we're going to be using a denture as the foundation of their provisional. When we're all done with it, it's going to sit on the ridge and it's going to be attached to implants. So it'll be an acrylic bridge if you look at it that way. And then our final restoration will be either, we'll talk about, there's 3 different options that we can do. So as Jason pointed out, one of the most important things about this is if we start in the right direction, we're going to get a much better result. So sometimes we kind of think, oh, it's just an immediate denture, whatever. But that's what the person's going to be wearing during the whole healing, and that's what they're going to start thinking of as their teeth. So if we spend a little extra time looking at the vertical dimension of occlusion, the bite, and the aesthetics, that sort of thing, then we've already got the case going in the right direction. And when we get to the final restoration, it's just a matter of kind of carrying forward the plan we've already made on our pre-treatment phase.
So this is an example.
So one of the things we want to look at, a lot of times, as you guys know, if a person has terminal dentition, a lot of times they've lost vertical. And we need 15 millimeters of restorative space, like Dr. Reddy mentioned, between the bone and the opposing teeth. But there's no law that says we have to gain all of that surgically. Sometimes a person may have lost 2 or 3 millimeters of vertical. So this is an excellent time when we're making the provisional to go ahead and open their bite up a little bit and get them an opportunity to adapt to that new bite before we do our final restoration. So we kind of want to, when we get these patients in, we want to look at them and say, where should they be? And use the provisional that we're going to make as a tool to get them there. So I have a couple steps here. You guys know how to do this, but a lot of times you want to start out by establishing the vertical dimension of rest, as you know, and then we'll just reduce that 3 millimeters to establish our vertical dimension of occlusion. we're doing
Implants going in.
We're doing a full arch rehabilitation, so as much as possible, we want to make CR and CO coincident. So when you're taking your bite for your pre-treatment prosthetic, which is often an immediate denture, it's helpful if you can establish centric relation for that patient, because again, that way they'll be functioning in CR the whole time they're wearing their provisional, and they'll be ready to go at the VDO you've established in centric relation when we go to make our final restoration.
I'm not even.
So again, talking about that. If we do have an edentulous patient, we have to go through a denture making process. Again, Dr. Reddy is going to pay for the laboratory fee, so you would need to do bite rims and setup, and just like you would for a normal denture. Many times the person has terminal dentition, so it's more taking models with good borders and a bite so that we can create the provisional prosthesis.
Thinking anymore.
Again,
I'm literally.
nice to do the bite in CR. So we want to make sure we get some good information. The high lip line for these devices is critical. And you gotta, one of the challenges with this is you have a patient that smiles like this. And then all of a sudden you get a prosthetic in and they're like, big smile. So you gotta figure out a way to see that big smile ahead of time, because we need to make sure that prosthetically and surgically, we have the finish line between the gums and the prosthetic hidden. You guys saw that picture that Jason had of the, or no, it's Dr. Reddy, of the teeth, where you can see teeth and pink and then gums here. That looks really, really bad. And the key to avoiding that is making sure we understand how far up we need to move the tissue to hide that transition line. We want to look at the low lip line and kind of see, does the person show any teeth when they're relaxed? When we set the teeth for the provisional, we may want to lengthen them a little bit to show some teeth for the person. Lip support. How is the person's buccal position of their teeth? You know, do they need a little bit more support, or conversely, are the teeth flared out a little bit and need to bring them in? And then, of course, our midline and our incisal edge inclination, and also our buccal corridor. Sometimes we look at the front six, and we can take some time to look at that buccal corridor because we're changing all the teeth. So we can go ahead and fill that in a little bit if the person has a lot of dark space at the edge of their smile.
Cutting by numbers.
So it's nice to have some pictures for us because we don't get to see the patient. So if we have the models and the pictures, then that gives us information we need about where to cut to and how to set the teeth, things like that. Many times we're not going to be able to do a try-in because a lot of times these people will have anterior teeth. So the try-in will be day of surgery, basically.
Now it's pretty.
So it shouldn't take more than 2 appointments to get a provisional made. Either you'll be doing 1 appointment and sending in models and information to make an immediate denture, or immediate dentures if we're doing a full case, or you'll be doing 2 appointments to do a bite registration and then go to a finish. We could do a setup in between if you like, but oftentimes if you use that upper bite block, sometimes it's easy to think of it as just a big chunk of wax that the person bites down on, but you can give us a lot of good information. When we take that bite block, we set the teeth even with that buccal surface of the wax. So if you sculpt that a little bit, that shows us exactly where we should be in terms of lip position. The bottom edge of it, the occlusal edge, is where we set the incisal edges of the teeth. And in the posterior, we follow that angle for our buccal corridor. So if you shape that up a little bit, if you treat that wax like it's set teeth, then we just set the teeth right to that, and the person's going to have that same position. They're just going to have, obviously, it'll look nicer because they'll have teeth on it. Again, Dr. Reddy pays.
Amazing.
So chairside conversion. We're going to have a guide based on what's appropriate for the case for Dr. Reddy, and he'll do what he showed. He'll do all the surgical work for the case. And then what a conversion is actually is we're going to take that immediate denture and we're going to connect it to the fresh implants and the multi-unit abutments using temporary cylinders. So we'll go ahead and index it. We'll attach it with liquid PMMA. And then we cut off all the flanges. So it's kind of, Sometimes we think of it like a denture because it looks like a denture, but when it's all done, it's not going to be much like a denture. It's going to be flat on the bottom. It's not going to have flanges. It'll have even occlusion. It'll be set for crown and bridge type occlusion, not denture occlusion. I'll have centric occlusion and anterior guidance, all that sort of thing. And if we do a good job of getting the planning done, it's going to look really nice for the patient. It's going to be the template that we're going to be following then a few months down the road once the surgery's done. A couple things I wanted to mention about it. Those multi-unit abutments, as a restorative dentist, those are your best friend, because if you think about sometimes how tissue can be hard to work with on a single implant, multiply that by 4 and have angulation issues, it can be very, very difficult to do this kind of restoration to fixture level. So by getting those abutments up to tissue level, it makes all the try-in appointments go much more predictably and I'd say easily for you. Okay, so and then that's what happens chairside. So as Dr. Reddy said, he'll make sure that the case is equilibrated, very close. And that prosthetic is the thing that's going to hold those implants in place too. So it's really important. If it breaks, it can lead to implant failure. So it's really important that the patient take good care of it, and also that we get nice even occlusion on it. It'll be designed for even occlusion all the way around the arch, and you want to make sure that it's equilibrated well so that we're not overloading any of the implants during the healing process. So at this point, there's about 4-month gap. And then we'll move on to the steps that would be involved. So these are all the steps that we did so the person could get their teeth in a day if they choose to do that. Now we're moving on to the final prosthetic. We talked about this, so I'm going to skip this. I'm trying to follow Jason's good example here. All right, so once so everything's good, Dr. Reddy says ready to restore. So we'll get going on the case. So as was mentioned earlier, you'll want to go ahead and take a fixture level impression with an open tray, and you'll be working to the multi-unit abutments. One of the other things that's nice about that is, for those of you that haven't used them before, regardless of what platform is, well, regular or narrow platform implants have the same. So you're going to have most likely 4 or 5 sites that all use the exact same components on it, which makes it pretty nice to work with. So you go ahead and take your open tray impression and send that in to us, and we'll go ahead and make a model, obviously, and we'll make a bite rim. And we're going to make a bite rim that'll be retained by a couple of the implants so that you'll actually screw it onto the implants. And then we'll make what's called a verification jig, like that. And what the verification jig is for is when you bring the patient back, once you take the provisional prosthetic out, you'll go ahead and seat that. You screw down all 4 of the abutments, or 5, however many there are, and then take out all but 1 and take an x-ray. Because what you want to make sure is that this will seat perfectly on that in the mouth the same way it does in the model. That way, when we make the rigid frame, we know that it's sitting passively on the implants. If for some reason it's a little bit different, you do, like in this picture, section it between one of the implants and then lute those pieces together, and then we'll alter the model accordingly. If 2 are off, I would say take another impression, because those frames, they're difficult to make, they're expensive, and it's better to make them once and have them right. The reason we like to do the screw retain bite blocks is that many times dentures have a flange, and because they have a flange, you can pretty much put the teeth anywhere. What happens with that 15 millimeters, if you think about a typical central being 10 or 11 millimeters, we only have 4 millimeters below there to kind of get that nice shape into the tissue. So we want to start early in the process of seeing exactly what that emergence is going to look like, so we have a nice shape for the patient. We don't wind up with a ledge down there or something like that. So by doing everything screw retained right from the get-go, we're showing the patient more how they're going to be at the end. Going through doing the verification jig. All right, so you send that back to us. We'll articulate the case. We like to have a model of the provisional with a bite, and we'll cross-mount that with the master model. So that way we can use, again, the tooth position, all the good aesthetic and occlusal information that you guys have developed with that provisional, then we can carry it forward into the prosthetic. So we'll go ahead and set teeth on that screw-retained bite rim so that way when you get the case back, you'll be able to screw, again, 2 screws, not all the screws, but 2 screws, and you'll be able to screw in the try-in as well to check everything. Basically, check the aesthetics, check the phonetics. You want to be picky on this because most of the final restorations that we're doing are going to be very difficult to change very much. So, sometimes it's like, it's just a setup. With this, you want to say, hey, it's the mock-up of the final. So if you see some things and you're like, I don't really like it, it's like 80% of what I want, let's get it to 100% before we transition to the final. Again, check to make sure it's working properly. It's really nice, even if you like the occlusion, it's nice to go ahead and take a bite over this. It gives us one more opportunity before we make the final prosthetic to really hone in that bite and make sure you get a good result with the final. And we'd say this is a little over an hour for this appointment. All right, so this is the little bit longer appointment because this is where we'll actually make the final prosthesis. And what we're going to plan on doing for you guys, unless you prefer something else, is we're going to do a crystal ultra restoration. And what it is it's a high-strength fiber reinforced bar with a nano hybrid composite shell on it. And what's nice about that is it looks like denture teeth and plastic, but what it actually is it's a one-piece hybrid composite with pink coloring on it, essentially. And so if for some reason the teeth can't break out per se because it's all one thing, so that'll be nicer for you. And if for some reason you get a little chip or something like that, you can do a direct repair if you like. It's composite, so you could repair it just like you would any other chairside thing, which kind of helps with, so the people don't have to have their teeth out as much. Note, have them save their provisional just in case something goes awry, because then they can have that as a backup. So yeah, about that. So again, you got a nano hybrid composite on the outside, which is about twice as strong as really good quality denture teeth. It's all one piece. And one of the nice things about the composite is that zirconia is great. It's very sturdy. In some cases, if you do zirconia against zirconia, you can get a little bit of clicking. And so this is nice because, of course, it doesn't click. So this is kind of talking about all the nerdy stuff about what we're making it out of. And, we're lab people. We love that stuff. We also are going to offer, as Jason said, we'll offer the 2 Noble Procera products, the traditional hybrid with a titanium framework in it and wraparound teeth. Or if you like to do the new zirconia implant bridge, which are really, really nice. We've done a couple of those already and really enjoying those. We can definitely do that for you as well. Again, the fees are covered by Dr. Reddy, so it's more what you would prefer from a clinical perspective rather than, well, this one's less or this one's more. So your next appointment is going to be delivery. So you shouldn't have to, we've worked in the bite, we've been picky with the aesthetics, we've tried the speech, phonetics, all those things, so the person's pretty much knows what they're going to get. So it's mostly just take out the provisional, screw it in. You'll want to double check, make sure you got nice adaptation to the intaglio, of course, which will be stable at that point, as you guys know. And then you'll want to double check the occlusion, make sure that looks good. Everything else we've already handled as we've gone through our try-in process. And this is the money appointment for you guys, just because this is where the patient's like, oh my goodness, I got my teeth, and there can be tears. It's an exciting moment for people. So, Dr. Reddy pays for all the lab work. I estimated 7 hours of chair time, which is a little more because that includes both beforehand, before the surgery, getting ready to make the provisional, and then all the steps that would be involved in making the final restoration. It could be a little bit less than that. And then once you decide what your fee is going to be, you can combine it with Dr. Reddy's fee for the rest of the package, and you'll have a number that you can easily present to your patients. And we've all made a commitment that we'll complete the case for that